Our next speaker is also very passionate about what he does because it's a very specialized field of pulmonary hypertension. My colleague, Dr. Guha, is the director of pulmonary hypertension and right heart failure program here at Methodist. He's our assistant professor of cardiology, and we welcome Dr. Guha.
Thank you. So in the interest of time, since got about 10 minutes left to cover a day's long topic, so we'll get started. So I wanted to talk today about pulmonary hypertension. And, for people who are unfamiliar with pulmonary hypertension, this is the heart and lung circuit where the deoxygenated blood comes into the right side and then gets pumped into the lungs through the pulmonary artery, and then the oxygenated blood comes back into the left side. Now, what we are dealing with today is mainly elevated pressure in the pulmonary artery, and that could be due to various reasons, as we will find out in the next few slides. So the definition of pulmonary hypertension is mean pulmonary artery pressure over 25 as measured by right heart catheterization. I want to emphasize on this. And now in patients who have pulmonary hypertension, a subcategory is the patients who have pulmonary arterial hypertension, and that's defined by pulmonary vascular resistance greater than 3 Wood's units and with a wedge pressure under 15. So just going back to the previous slide, as you can see here, this is the right side, and this is the pulmonary artery. So when you have just increased pressure in the pulmonary artery without elevation of pressure in the left atrium, or which is equivalent to the wedge pressure, then that is what we call as pulmonary arterial hypertension or pre-capillary pulmonary hypertension. Now, what we'll talk more about in the later slides is something called post-capillary pulmonary hypertension, where the elevation in the left atrial pressure leads to pulmonary hypertension, which is the most common form of pulmonary hypertension. So this is the classification, the latest classification of pulmonary hypertension. And as you can see here, the number 1 is the PAH, which is pre-capillary pulmonary hypertension. And this is associated with connective tissue disease, HIV infection, patients with liver disease, and most of it is actually idiopathic, where we really don't know a cause. Now the second so this is not as common as PH due to left heart disease, which is the most common, which is what we saw as post-capillary pulmonary hypertension. Now, for this talk, I'll be talking about group 1, group 2, and group 4 pulmonary hypertension. Now, group 4 pulmonary hypertension is chronic thromboembolic pulmonary hypertension, which is due to clots in the lungs with patients with previous PE. Now, this slide shows you what happens to patients with pulmonary hypertension, where they start off with lower pulmonary arterial pressure, which increases over time, and then eventually, as the right heart fails to pump against that high pressure, the cardiac output falls, and in these patients, the pulmonary pressures fall as well. So, in whom should you all consider PH? So, PH is one of the most common causes of unexplained dyspnea. So when patients are presenting with exertional dyspnea, syncope, or sometimes even with angina, those are the patients in whom you should consider PH, especially when you've done everything else to rule out. When patients come to you with unexplained dyspnea, the most common causes are either patients have angina or it's an anginal equivalent due to coronary artery disease, or patients have had a history of smoking, they have COPD or asthma. Now, you've looked at all of those and it doesn't fit any of these, that's in whom you should consider PAH. And this is from the NIH and the REVEAL registry, where they looked at the most common symptoms in patients with pulmonary hypertension. And as I said, dyspnea is the most common symptom, followed by fatigue, chest pain, and near syncope. Now, what are the physical findings in these patients? Most of them are due to right-sided heart failure because the right side pumps into the pulmonary artery, and if the right side fails over time, you will see signs of elevated JVD, tricuspid regurgitation, loud P2, right-sided S3 gallop, peripheral edema. And the most common or the first sign that you will see that somebody has pulmonary hypertension is a sign on the echo where they look at the tricuspid regurgitation jet. And when you see an echo report which says that either the RV systolic pressure is over 40 or the estimated PS systolic pressure is over 40, that should ring a bell to you that this patient has PH, because when the systolic pressure is over 40, that usually equates to a mean pulmonary pressure of over 25. And as you saw in the definition, that characterizes pulmonary hypertension. Now, this is a normal echo, and this is the LV, this is the RV. And this is the patient with pulmonary hypertension where they have a really small LV and a large RV, because the RV is really enlarged to be able to pump against elevated pulmonary pressures. So, however, one thing I wanted to bring up here is that just because they have pulmonary hypertension on echo does not mean that they have PAH. So most often, like we discussed, the most common cause for pulmonary hypertension is left heart disease. And in this study from Australia, only about 2.3% of the patients who had elevated PA pressures on echo ended up having pulmonary arterial hypertension. Now, this is to demonstrate that if your patient has persistent dyspnea on exertion which is unexplained and the echo does not show that the PA pressures are elevated, it does not rule out pulmonary hypertension. There are almost about 10 to 20% of the patients where your pulmonary artery pressures could be high, but on the echo it is read as lower, mainly because of technical issues. So what are the things you should do if you have an index of suspicion that the patient might have pulmonary hypertension? So you get an echocardiogram, then you get a VQ scan to rule out chronic thromboembolic pulmonary hypertension or group 4 pulmonary hypertension, and then you get an overnight oximetry to rule out obstructive sleep apnea. Then all the other things that we looked at group 1, which is HIV, patients with portopulmonary hypertension, or patients with connective tissue disease. So you look at get their HIV, ANA, LFTs. And then the real gold standard here is to get right heart catheterization to confirm diagnosis. I'm going to skip this slide. And really, chest X-ray, other than seeing this peripheral plethora, it's not very useful. And one thing on CT scans, now that you get CT scans on almost everybody who has shortness of breath, one thing to pay attention to is the pulmonary artery size. So normal pulmonary artery size in women is about 2.8, and in men it was about 2.9 to 3. So anything over 3 on the CT scan, especially if it's definitely close to 4, should ring a bell that the patient has had persistent elevation in pulmonary pressures. So that is another thing to look out for on CT scans. Now, just wanted to spend a couple of minutes on right heart catheterization. That really is the gold standard, because that will give you a wedge pressure as well as the mean PA pressure so that you can make a diagnosis of pulmonary arterial hypertension. And also, at the same time, we do acute vasodilator challenge where we give patients nitric oxide or Flolan or adenosine to see if there is reactivity, because that will determine if the patients would benefit to calcium channel blockers or not. Now, about 3 minutes to talk about pulmonary arterial hypertension therapy. So we'll switch gears here and Really, the goals of treatment here is to make patients feel better and hopefully and improve their survival. And the goal really is to support the RV. So these are certain general treatment measures. Most of the times when patients present with pulmonary arterial hypertension, they're already about 2 or 3 years, of symptoms. So there's always a delay in diagnosis. So most of these patients will come to you with some degree of right heart failure. So oftentimes you will need diuretics, and one of my choice is really to add aldactone because a lot of these patients have hyperaldosteronism secondary, and they respond very well to aldactone along with low-dose Lasix. And if they need oxygen, they need to be put on oxygen. And digoxin, again, can lead to some modest degree in cardiac output and can be used in these patients. Looking at 3 major pathways for treatment of pulmonary arterial hypertension are the endothelin pathway, the nitric oxide pathway, and the prostacyclin pathway. So, about almost 15 years ago, there was only one drug to treat pulmonary hypertension, and that was prostacyclins here. And all of them were used to be on IV therapies. But right now, I think we have about 14 medications, including oral, inhaled, and IV therapies and subcutaneous therapies to treat pulmonary hypertension. So just to go over some of these medications, the ERAs, I'm sure you've heard of some of them, ambrisentan or Letairis, bosentan or Tracleer, macitentan or Opsumit, sildenafil and tadalafil. This is sort of the new kid on the block, which is a soluble guanylate cyclase stimulator, or riociguat. This is an oral prostacyclin receptor agonist called selexipag, which is also very new. And then there are these 3 prostacyclin analogs. So just some specific features of PAH therapies. Again, ERAs, these all of them are oral. They're very effective in the initial treatment phase when patients don't have marked RV dysfunction, and they really act on the fibrosis pathways and help with decreasing pressures. Now, this is not very effective in functional class 4 patients and often lead to fluid retention, worsening their RV failure. Now, PDE5 inhibitors, they're almost ubiquitous now, like a lot of patients are on it, even coming to us. These are sildenafil and tadalafil, which are fairly well tolerated with very few side effects. Only thing is, as the disease progresses, their efficacy goes down with time. And the side effects really mainly are headache, nausea, and hypotension, and rarely they can get some ocular side effects or ophthalmologic issues. Like I said, one of the newer medications is riociguat, which is more potent. It acts in the same pathway, but is more potent than PDE5 inhibitors. So kind of later in the disease, because it's nitric oxide independent, it can be used. And this is really the only medication which is approved for CTEPH, or group 4 pulmonary hypertension. Again, this is approved only in patients who are deemed non-operable. We'll talk a little bit about that if the time allows me to do so. Now, prostanoids, like I said, these are really reserved for patients who are functional class 4, which means they can't really move around even at home, and they have symptoms at rest. And these are very effective. But the only thing is that you have to give it through IV and a continuous infusion. Now, there are subcutaneous infusion options available too, but they do have more pain and other side effects. I'm going to skip on these role of calcium channel blockers for interest of time. And I just want to leave you with this and maybe a couple more slides if Alpesh will let me do it. Now, I think it's really important to recognize where your patients are. When somebody presents to you with repeated syncope, they're really, really sick. These are patients who are going to die within the next 6 months. So these are patients who need to be initiated on IV therapies. The patients have class 3 symptoms. This is where you can use oral therapies to see if they improve and declare themselves. If they progress to class 4, then you can add on IV therapies, but a lot of them improve to class 1 or class 2. Now, just 2 words on CTAF. This is potentially a curative form of pulmonary hypertension where patients have had clots over time. So it's really important to recognize them because a lot of times about 3 to 4% of PEs do not resolve, and over a period of time develops chronic clots, which can be removed with surgery. And the diagnostic modality of choice here is a VQ scan. So a CT scan with contrast that we often get, a CTP protocol, will not diagnose this. So if you are suspecting CTEPH, please get a VQ scan, which can diagnose chronic PE. And I just wanted to skip to this. This is what the clots look like when they pull it out after surgery. And we are starting a CTEPH program here where we will be able to offer surgery and hopefully percutaneous techniques soon. So just to summarize, again, a lot of advances have been made in the field of PAH over the last 10 years. And I think it's really, it's on us as gatekeepers to really recognize these patients who have unexplained dyspnea for a long time and keep this in your differential as you take care of these patients. And timely evaluation is key. And if you have any questions, I have my number listed here. And Dr. Park is a world-known expert in pulmonary hypertension, and me and her take care of these patients. So I'll be available for any questions after this too. So thank you very much.